I'll start the recording. Good afternoon and welcome to today's Tuesday topic, after intubation, what's the next most important step in mechanical ventilation? Now, this is a basic overview of what we need to be considering when we're talking about our patients. And I always like to start off reminding you about your major issues when you are ventilating your patient. Now, that's whether or not they're intubated. If you're using high flow, you're using CPAP or BiPAP, non-invasive, or intubation. 4 questions should always be answered before you walk away from your bedside, before you give handoff to anyone else. And those 4 major issues: number 1, is your patient appropriately oxygenated? That's so incredibly important. We're going to talk about measuring appropriate oxygenation, what the tools are really for that, so that we have a relatively good idea about what's occurring. Is your patient actually able to remove carbon dioxide, the major respiratory acid byproduct of metabolism? And are their lungs easily distendable and therefore what we call compliant? And in relationship to the first 3, are you actually recruiting their alveoli? So with basic strategies and understanding, we should be able to answer these 4 major questions about what's next after intubation when we're evaluating our patient. So I just want to quickly, I'll talk a lot more about this, just quickly taking a look at the most prevalent ventilator that we have here at Grady. This is the 840 Puritan Bennett. If you look down here, you see the mode of ventilation, which is SIMV, the target of ventilation, which VC means volume control. Over here, you're going to see what FiO2 the patient is on, how much PP is on, and then we're going to move up here. You see that small square. There really are 3 different squares that we can see. We see the C, it's inside of a green square. That means that is the mandatory breath. And A means it is an assisted breath that was designated when the patient made an effort. And A will also be inside of a green box. And S means a spontaneous breath, and that will be inside of a red box. Next to that, you see the peak pressure. That's the pressure that is generated as gas flows down the conducting airways, ultimately to land in the alveoli. So it's from conducting airway to alveoli. That's your peak pressure. The mean pressure is the constant pressure that is sustained and maintained to keep your alveoli open. So conceptually, when we think about mean pressure in the airways, I want you to think about it like mean pressure in the arteries. It's the pressure that is required to keep the conducting airways and the alveoli open. And it's an incredibly important component in the understanding of mechanical ventilation. Next to that will be PEEP. I'm going to skip over I to E. That's really not part of a basic class. The total respiratory rate, that means what you've dialed and what the patient is breathing. Here it's exactly what's been set. So it's patient is not over breathing the ventilator. This is the exhaled tidal volume from the alveoli, and this is the minute ventilation. Now we're going to come back to each one of those, but I just want you to know just about everything you need to know is on the front of your ventilator on that ventilator screen. So I just want to make sure we appreciate we're really talking about 2 major principles here. Is my patient able to remove carbon dioxide? Now, that is actually what we talk about when we talk about ventilation. And the primary way that we assure CO2 removal, primary way, is through the manipulation of minute ventilation. Minute ventilation is the amount of gas the patient is exhaling in a minute, and that's normally around 8 to 10 liters per minute. That's the normal minute ventilation. But if I have a patient who is compensating for metabolic acidosis or who is attempting to compensate for respiratory acidosis, he will increase his minute ventilation if he's capable. Minute ventilation is respiratory rate, or what's known as frequency on your ventilator, times tidal volume. Now that's incredibly important because in today's ventilation world, one of the first things we do after intubating the patient is we may make a decision to reduce the tidal volume. When you reduce the tidal volume, you're going to reduce the minute ventilation. So any reduction in tidal volume must be accompanied by an increase in the respiratory rate. So that's a really important thing for us to understand, because our provider may come by and say, oh, I want to reduce the tidal volume. And sometimes the tidal volume gets reduced, but the respiratory rate doesn't get increased. And then you come back later and you say, oh, the patient's retaining CO2. And everybody says, well, that's okay. We reduced the tidal volume, and that's why the patient is retaining the CO2. But we don't have to let that happen, and it can be very dangerous. So typically, anytime the tidal volume goes down, we're going to go up on the respiratory rate. Now, a lot of things actually are going to affect our minute ventilation. So this looks like it just got a little messed up when I was doing this subset. Minute ventilation is regulated by your brainstem, and your brainstem responds to an acidotic pH, so pH going down, and the CO2 going up. And those can happen independently. pH might be down because we have metabolic acidosis, but I'm going to increase my tidal volume and respiratory rate if I'm able. I haven't been paralyzed by a spinal cord injury or paralyzed by my provider and nurse through the administration of neuromuscular antagonists, right? As long as I'm not paralyzed, if I'm capable, I'll increase my own minute ventilation whenever I have an acidotic pH. So you come in the room and you see your patient is breathing 26 times a minute. You had set the rate at 12 or 14, and he's breathing, so we'll say 14. He's breathing 12 times above that 14 for a total rate of 26. That is an attempt to increase his minute ventilation. You have to ask why. Really, really important to remember that anything that promotes hypermetabolism, things like fever, like septic shock, like traumatic injury that occurs in the OR, not necessarily in a motor vehicle collision or a gunshot wound, but just the trauma of going to the operating room, and also overfeeding, which will all cause CO2 to go up. And as CO2 goes up, the burden on the lung is to increase minute ventilation. And the easiest way the patient can do that is by increasing his respiratory rate. So it's always really important to remember, even prior to intubation, patients who have a sustained rapid respiratory rate are letting you know that they are compensating for something. Now, it's not always obvious what that something is. We have to pursue this. We have to actually evaluate the patient and try to understand why is increasing his respiratory rate. And for me, before I would ever suppress someone's respiratory rate, as a bedside nurse, I'm seeing that the patient is breathing rapidly. I feel like he's agitated, he's overbreathing the vent. I call the respiratory therapist. Most of the time, the first thing the respiratory therapist says is increase sedation. Okay, I'm going to do that. No, because what I'm doing is trying to make my patient fit the ventilator instead of trying to figure out why he has this high minute ventilation, respiratory rate times tidal volume. Now, another issue that can occur is when we have decreased functional lung surface. Functional lung surface that occurs with pulmonary contusion, with cancer, with atelectasis, with ARDS, and also when we have reduced blood flow through the lung. Now, reduced blood flow through the lung can occur when we have a big PE. It can occur when you have a right ventricular infarct. It can occur secondarily to high PEEP, which then obstructs blood flow through the pulmonary vault. So again, ventilation is not just about turning knobs and buttons on the mechanical ventilator. It's really about trying to understand the message the patient is giving us that is portrayed by his respiratory rate and tidal volume and some other things, and by his blood gas, and by trying to understand the message that the patient is delivering to us. Now, in general, if CO2 in the blood is high, that's the partial pressure of arterial carbon dioxide. Typically, what I'm going to do, the first thing I'm going to think about is that I'm going to protect his lung by reducing his tidal volume at the same time that I'm going to increase CO2 removal by increasing his respiratory rate. So whenever you hear anybody talk about lung protective ventilation or low tidal volume ventilation, that is always about protecting the lung from shear force injury, from over distension. And you always need to consider and have a discussion, should we be increasing the respiratory rate when we're reducing the tidal volume? Now, everybody isn't going to comply with that. They're not going to agree. There may be many reasons that they don't want to do it, and then that's okay. But we must have a conversation about increasing respiratory rate when reducing tidal volume. Second principle is promotion of oxygenation. And there are really two really important things about oxygenation in the lung. Oxygenation in the lung is by the matching of blood and gas. That's matched in the middle range of the lung, that's known as zone 2, where the pressure of arterial blood is higher than the pressure of alveolar gas, which is both higher than the pressure of venous flow back to the left heart. Now, not necessary for us to go into that depth in this basic course. It is something that is incredibly important for us to understand. But in the basic course, I just want to remind you, sometimes you have patients who have failure of oxygenation, not necessarily because you're not doing a good job with the ventilator, but because they may have limitation, right ventricular ejection and blood flow through the pulmonary vault. So that's always something that we want to consider. Probably needs an ultrasound of the lung, an ultrasound of the heart. We really want to match gas and blood from the heart, gas in the lung, and try to achieve a match that's called the VQ match, so that anything we're adjusting with the ventilator, we may need to actually also adjust pulmonary blood flow. Sometimes we can do that with dobutamine or milrinone or sildenafil, Flolan, Viagra, prostanoid, nitric oxide, whatever your choice is and whatever is available to you, whatever you feel works best in your patient. So when we're making adjustments to oxygenation and our patient is deteriorating, we have to consider that they may not have very good blood flow. So that's really part of a basic evaluation of mechanical ventilation. Now, the primary goal of oxygenation is to get oxygen into the alveolus and support the transfer of oxygen from the alveolus into the blood. And we're going to measure that in general. The best way to measure it is by PaO2. Lots of times we're just going to use SpO2 to tell us about gas exchange, and that's okay too, unless your patient is refractory, and then you definitely need to have an arterial gas. Now, historically, in life gone by, we talked about the difference between the gas I delivered into the alveolus and the gas that I saw in the arterial blood. And that's called the AADO2, or the difference in alveolar and arterial oxygen, also known as the AA gradient. We rarely calculate that anymore. It doesn't generally even come back on our blood gas. What we use today is to say, did the gas in the blood reflect the gas I was delivering to the patient? And that's called the P to F ratio. From my point of view, as any nurse caring for any critical patient who is intubated on a ventilator, doesn't matter to me where you work. I don't care if you're SI, MICU, CV, 12A, ECC. You must know this. You must know it. It's simple math. Patient's PaO2 divided by the FiO2 in the decimal, meaning if you're on 100%, that's 1.0. You're on 50%, that's 0.5. PaO2 divided by FiO2. And that should always be greater than 250. Now, I'm giving the patient 100% FiO2 and his PaO2 is 100, and I think that's fantastic. But when I look at 100 divided by 1.0, that correlated ratio is 100. That patient has complete and utter respiratory failure. This is one of the most important things I can say to you about basic evaluation of ventilation. Number one, you're going to evaluate the presence or absence of CO2. You can do that with end-tidal, you can do it with PaCO2, you can even do it with PvCO2. And number two, did the oxygen you give the patient reflect in the blood? So that's the P to F ratio. And that's PaO2 divided by FiO2 in the decimal. That should always be greater than 250. Now, there's a scale that we use. It's from a criteria called the Berlin criteria. I'm not really worried that you have that memorized. I'm saying to you that if your P to F is less than 250 and you're on a high FiO2, it's telling you that the gas you're giving the patient is not getting into the blood. That's the simple strategy here. So what am I going to do to try to improve gas exchange? Well, first of all, I'm going to try to open the alveoli. And second of all, I'm going to try to assure that the patient has blood flow. That to me seems very strategically important in very basics of mechanical ventilation. Looking at the PaCO2, looking at the P to F ratio, I never care and never want to hear from any nurse calling me to ask me a question. I never just want to hear about their PO2. I want to know what their PF ratio is, because that's what tells me about whether or not they really have oxygenation failure. So typically we say a P to F less than 200 on 5 or more of PEEP means that you have significant, profound respiratory failure. I think we should be evaluating patients who are less than 250. And we should be adding PEEP. So now we're on PEEP, and now we're saying if you're less than 200 on 5 or more PEEP, you have mild respiratory failure. You can't use it to diagnose ARDS. You need some other information for that. But you can say the patient has respiratory failure. And the lower the PF ratio, the worse the lung is. And if you don't advocate and get something done for the patient, you're the provider on the night shift and you say, well, I'm going to wait for the morning. Okay, well, now my patient spent 12 hours virtually hypoxic with me blowing a lot of oxygen at them, and that actually proliferates lung failure. So I really have to strategize here to be sure that I'm gathering my data appropriately so I can have good communication as bedside nurse to provider, as APP to the attending, as residents to the attending. And when you feel like you're putting something forward that's really important, you should escalate that if you're not getting the response that you need. Don't need to escalate everything, but sometimes we do have to escalate in the best interest of our patient. So typically, if my patient's oxygenation, that would be their PaO2 in relationship to the FiO2, is poor, we're going to go up on the FiO2, which is the dirtiest down and dirty way I can increase my patient's oxygenation. But my goal is always to get FiO2 down, and I'm going to do that by going up on PEEP or by increasing the mean airway pressure. Now, mean airway pressure, remember, just think about it like mean arterial pressure, is the pressure that is necessary to keep the lung open. So there's lots of strategies that we can employ for that. Again, a little bit beyond the basics of ventilation. I talk a lot about these strategies. They are really, really important. But very first thing is increasing PEEP. Okay, so now here is the slide I mentioned before. When I look at I come into the patient's room, I'm on rounds, I'm the nurse responsible. I cannot just say, well, respiratory therapy takes care of the ventilator because you're taking care of the patient. So you really have to look at the ventilator. So we're going to just remind ourselves, up here, we're looking at breath type. Assist will be in a green box with an A. The controlled or mandatory breath will be C in a green box. And if the breath is spontaneous, that means the patient initiates and has partial support from the ventilator, not full support, that will be an S inside of a red box. Down here, primary modes that we use here, and there actually are 3. Assist control, that's AC, spontaneous intermittent mandatory ventilation, SIMV, or pressure support ventilation, PSV. Those are the primary modes we use here at Grady. And then we think about the target. The target can be either volume or pressure. And on our current ventilators, what we call pressure limited or pressure regulated volume control, meaning that I'm controlling both of those variables, and that's known as VC+. VC+ is a really friendly mode to put patients on when you perceive that they are overbreathing the vent. Sometimes it's because the flow of gas is too slow. We put them on VC+, that flow rate, how fast we're delivering the volume or the pressure. That flow rate will be variable depending on the patient's lung compliance. It's a really super friendly way to ventilate patients, not when they're very first critically ill, but as you are moving towards an approach for thinking about weaning the patient and getting them off the ventilator. Then we have some measured things, total respiratory rate. So you can see down here, assist control at a rate of 20, and the respiratory rate is 20, which means the patient's not overbreathing the vent. I'm just giving him 20 breaths a minute. His exhaled tidal volume, VT means tidal volume, E means exhaled here, and that's the exhaled tidal volume. So he's on a tidal volume of 400, but he's exhaling 420. Now on his next breath, he might exhale 350, and on the breath after that, 410. So it's not going to be an absolute match to the tidal volume that you have dialed on your ventilator. Sometimes the patient's fully empty, sometimes they don't fully empty. And so we look at the exhaled tidal volume to kind of tell us about the return of the alveoli, right? We distend it with the gas, and then the alveoli recoil and push the gas out. So we'll look at that exhaled tidal volume to make sure that we're not trapping a lot of gas in the lung. That gas, if we trap it in the lung, is CO2 rich, and the patient's CO2 will eventually go up. And over here, V with the dot, that means minute ventilation exhale total. That's the minute ventilation, 8.37. Now, it's not going to be the same number, this number, 8.37, as frequency times tidal volume. It's not going to be exactly the same because we're going to exhale more and less tidal volume with each breath. And then down here, we're looking at your FiO2. This patient's on 35% and a PEEP of 5, okay? So he's on very minimal oxygenation settings. That must be because he's doing quite well in terms of oxygenation. And it appears here that the bigger concern for our patient in this setting, the bigger concern for this patient is actually removing CO2. That's why we're adjusting his respiratory rate and his tidal volume and his minute ventilation. He's oxygenating pretty well. I'm assuming that because I'm looking at his settings. Okay. So all those things are really important when we're evaluating our patient. And that brings us to appreciating the modes of ventilation, okay? So modes of ventilation, people talk about the mode. Mode is not volume, mode is not pressure. Mode is, am I controlling every breath with full support, or am I allowing the patient to have partially supported breaths? That's it, okay? Assist control, even if the patient makes the effort, that turns the breath on and the patient gets a full supported breath. So assist control, every breath is a vent breath, even when the patient asks for it. So I put the rate at 14, he's breathing 22 times a minute. Every single breath looks just like the other, and he gets full support. With assist control, every breath receives full support. With SIMV, the M stands for the mandatory breath. So there is a mandatory rate. It might be 5, it might be 8, it might be 12, it might be 20. All mandatory breaths get full support, just like ACMV. Same thing. Mandatory breath always receives full support. So when you're on SIMV and you've set your rate at 20 and the patient isn't overbreathing the vent, he's getting 20 breaths per minute. It says SIMV, but the patient is actually on assist control because he's not breathing above the ventilator, okay? So SIMV, mandatory breaths receive full support, and spontaneous breaths, which are not mandatory, they are above and beyond the mandatory rate, they get partial support. We no longer put patients on SIMV without some kind of a support. So the support that we're going to give a person who has SIMV is every mandatory breath, that's the rate we set down at the bottom, every mandatory breath gets full support, and their spontaneous breaths get partial support. And here at Grady, based on the kind of ventilator that we have, we give pressure support. Pressure support means that we flow gas into the airways, open the airway, making it easier for the patient to move gas back and forth across the alveoli. So pressure support means that we're going to set a limit on the pressure somewhere between 8 to 15 centimeters of water pressure. And I'm going to talk a little bit more about that in a moment. If you're actually working at another hospital, let's say if you're at Emory, you might also be using a Hamilton ventilator, and the Hamilton ventilator actually allows you to do assisted volume support. So you can actually support the patient with volume, not with flow of gas to pressure. So really, truly, we only use 3 types of ventilatory modes here at Grady: assist control, SIMV with pressure support, or pure pressure support ventilation. Pure pressure support ventilation means the patient doesn't have a rate. You should be using that only to determine extubation, and less putting patients on pressure support without a rate should only be allowed, my friends, only be allowed for 30 minutes before extubation takes place, or we put the patient back on a more restful mode. Leaving patients on pressure support without a mandatory breath is going to tire them out and ensure that they fail their extubation. Now, we as bedside nurses, we as bedside providers, we have got to tighten this up a bit because we're really poor at this here at Grady. We put patients on testing modes like pressure support, and we leave them there for 4 hours. That is inhumane and unacceptable. I'm so sorry to say it. It's just the truth. Pressure support ventilation just tells me, is the patient ready to be extubated? I don't want him to tire out. I'm going to extubate him. He might need to be reintubated. He might need to be extubated and transferred over to BiPAP, a non-invasive ventilatory mode. But to leave patients on pressure support ventilation for a day, 2 days, 3 days, 4 days, which I have actually seen here at Grady, not infrequently, this is not a good methodology for ventilating patients. If they just need pressure support, you can do that without the ET tube, and you can do it with BiPAP. So it really is important to actually be following what's happening. You're doing sedation testing and sedation holiday and spontaneous breathing trials, but you also have got to assure that we are not wearing our patient out, causing dysfunction, and disallowing them the capability for weaning off the ventilator. Okay, so that's modes. Then we think about targets. Targets are either to pressure or to volume, okay? So when we talk about assist control, we can be an assist control with a volume target. We can be assist control with a pressure target. Sometimes people will say pressure control ventilation instead of assist control, but really it's just assist control. Patient can make an effort to take a breath. The vent's going to turn on, fully support the breath. It's going to fully support the breath to a designated target of pressure or to a designated target of volume. When we talk about pressure ventilation versus volume ventilation, that is not about the mode. That's about the target. In general, we start patients always after intubation, we start them on a volume control, assist control, meaning every breath is a vent breath and the target is volume in general. Now, you might run across some physicians, pulmonologists, certainly if you were working in the neonatal unit or you already knew that the lungs were non-compliant, you might not start with assist control target volume. You might start with assist control target pressure. That's because in the non-compliant lung, the ventilator will force that volume into the lung regardless of the pressure, and that aggressive pressure target can actually cause very significant lung damage. So again, really thinking about the things in basic ventilation. What is your mode? Assist control, SIMV, pressure support. What is your target? Volume or pressure? What is your PaCO2? And what is your PF ratio? Okay, those are pretty straightforward. We've discussed all of those thus far. They're pretty straightforward. So again, remembering targets of ventilation. The device is going to flow gas into the patient and shut that flow off when a tidal volume's been reached. And it will deliver that flow of gas to the targeted tidal volume, no matter how compliant or non-compliant the lung is. So if I've got a stiff lung, the ventilator is going to force that gas into that stiff lung at a very high pressure because it's double blinded. The ventilator only cares about, did I achieve the volume that you've set? Pressure control. Gas is going to flow in to either a set time and or a set pressure, flowing the gas into the lung to a set time or a set pressure, and the breath's going to shut off. So you could reach that pressure and only be giving the patient a 50 or a 100 ml tidal volume breath, which would be less than adequate to remove his CO2. So really important to remember, typically we're going to choose to control pressure when the lung is non-compliant. Remember that initially we start with assist control, volume target. We're going to guide our adjustments based on our PaCO2 and our P to F ratio. So we think about the mode, we think about the target, and we think about the limits. We want to remember that in volume control, the device, our machine, our ventilator is going to flow gas into that lung to the target tidal volume, regardless of how much pressure is being generated, which means if my lung is really small and I'm forcing volume into that small lung, I'm likely to pop my lung, to develop a tension pneumothorax, to blow a bleb, and at the very least, to overdistend the functional lung and cause significant and severe lung injury, which is why we're very cautious about this. If the lung is non-compliant, we're going to put the patient on pressure control, and the device is going to flow gas into the lung to a targeted pressure, regardless of how much volume the patient is getting. Now, this is a lung protective mechanism. I'm saying to the ventilator, I understand that the volume may be extraordinarily low and it may not be enough for my patient to clear CO2, but I must protect my lung. And if my lung is small amounts of gas are going to yield a high pressure. So that's what's really important for us to appreciate and understand. Unless you are very, very experienced, you might not really be able to tell the difference when you're looking at flow, pressure, and volume in a volume assist control ventilation versus a pressure assist control ventilation. You may not be able to tell that difference very well, and that's okay. All I want you to see is every breath here. So every breath in volume, every single one is just like the other. But with this little dip here, what that's telling you is that you've generated a negative inspiratory force, turned on the ventilator, but every breath looks the same because we're in assist control, which means even if the patient is over-breathing the set rate, the ventilator turns on and delivers a full supported breath. Unlike SIMV, and again, looking at the difference between pressure SIMV and volume SIMV, I'm not asking you to see the difference. I'm asking you to see the difference here. This and this are your mandatory breath. Here's your patient's spontaneous breaths. So you can see that every one of the breaths in the pressure SIMV or the volume SIMV, every breath is not just like the other. There's variability because in a pressure SIMV, we go between a high pressure set and a low pressure set, pressure support, which would be 8 to 15, and pressure control, which might be up to 40. And in a volume-induced SIMV, the patient's going to move different volumes, and that's also going to generate different pressures. So again, all I want you to be able to look at is every breath just like the other, or is it not just like the other? This is assist control. This is SIMV. And if I put my patient on a rate of 20 and he's not over breathing the vent, but it says SIMV, every breath is going to look just like the other. Now, he probably is not going to be initiating his own breath, but every breath will just look just like the other. Okay, so I want to remind you, the goal of volume ventilation is to achieve a desired minute ventilation. That actually needs to match what the patient's CO2 production is and help to mobilize carbon dioxide out of the blood into the alveolus and out into the atmosphere. And our most important setting here will be respiratory rate and tidal volume. Many other things that are going to affect it. We're not talking about those today, but these are slides that I use in my more advanced class as well. So just want to remind you, you come to the bedside, you're looking at end tidal CO2, you're comparing it to PaCO2, and you want to remember that the goal of your volume ventilation is to achieve a minute ventilation that helps to remove CO2. If you're going down on tidal volume, you're going to have to go up on respiratory rate in order to ensure the removal of carbon dioxide. Now, when we set patients on ventilators today, we typically are going to look at a tidal volume breath somewhere between 5 and 8 mLs per kilogram, or 5 to 7 mLs per kilogram. We're trying to target a minute ventilation of 8 to 10 liters a minute. Remember, that's exhale tidal volume times the respiratory rate. And there's a lot of different things that we can look at to tell us where optimal tidal volume is. In today's practice, we typically will not initiate patients on intubated mechanical ventilation at more than 8 mLs per kg. Now, if I have a compliant lung, like a COPD lung, I might go a little higher. If I have a head injury, I might go a little bit higher. I don't want them to have such a rapid respiratory rate, so I might go a little higher on the tidal volume as long as their lung is compliant. The limitation on tidal volume is the loss of lung compliance. So when I have pulmonary edema, atelectasis, pneumonia, ARDS, hemothorax, pneumothorax, I lose lung compliance. I've got to adjust my tidal volume down because instead of having a nice big healthy lung, I have a little baby lung and it's really stiff and non-compliant. So I just want to remind everybody about predicted body weight. That has nothing to do with what you actually weigh. It has to do with your gender and it has to do with your height. Okay. But we can use some basic calculations here. Okay. So we're going to say ideal body weight is 105 plus 5, height minus 60, because we don't really care what you weigh. It's not really about your weight. It's about your thoracic cavity size. And for men, this is another formula. You don't need to use a formula. All you have to do is go to, and you can do it now or you can do it later, ARDS net, PBW, predicted body weight, ARDS net, PBW, predicted body weight. And that is actually going to take you're going to do a Google search. That's going to take you to a PDF, which allows you to look at the gender, the height, and what you should be setting the tidal volume at if you're trying to achieve 8 mLs per kg, 6 mLs per kg, 4 mLs per kg. The tighter the lung, the lower the tidal volume. The lower the tidal volume, the higher you're going to need to go on the respiratory rate in order to ensure that the patient has an appropriate minute ventilation. So we never think about tidal volume in isolation, never think about frequency in isolation, always think about minute ventilation. Okay. So we always want to remind ourselves that we don't want to harm our patients. So when they have non-compliant lungs, we're going to actually set the tidal volume lower to protect our patient. We're going to put the rate up higher in order to assure a good minute ventilation. The problem is the faster the rate, the less time there is for exhalation. So you also have to keep an extraordinary eye on time of exhalation. And you want to be sure that your exhalation time is 1.5 or greater your inhalation time. That's called the IE ratio. So we want to be, unless we're doing something strategically different, we don't want it to just be a consequence of the fact that I've increased your respiratory rate. I need to pay a lot of attention to time for exhalation because that's when the alveoli recoil and force the CO2 out of the lung field. Okay, if we're setting for pressure, reason we put patients on pressure control ventilation, remember, is because we've seen that the lung is stiff. The inspiratory pressure is high, the what we call the P plateau pressure is high, that what we're actually seeing is that we have a lung that has told us that it's smaller than it should be. It's less compliant than it should be, and I am overfilling the open lung. So I have to put that patient on low tidal volume and or pressure control to protect the functional lung. Pressure support ventilation. Remember, pressure support is not full support. It is a lower level of support. So now I'm going to just take a pause here. There's no slide for this. I want to make sure that we appreciate the difference between pressure control and pressure support. In pressure control, I'm going to set a pressure limit typically around 40 to 45, which means gas is going to flow into the lung until that pressure is reached and the breath is going to stop. And regardless of the tidal volume, the breath is going to stop. Okay? Pressure support is a mode that is used when patients have shown readiness to start weaning. So first, I'm going to give you pressure support on your spontaneous breaths between your mandatory breaths on SIMV. And the difference is that when I have you on pressure control, I've set that pressure limit at 40 to 45. Pressure support is the same thing. It's flow of gas, but the target is much lower. It's 8 to 15. If you ever get up to 20 with pressure support, you're giving your patient a vent breath. Just call it what it is. You've got your patient on pressure controlled ventilation. It just means that I'm flowing gas to a lower target. And I'm doing that because in order for me to breathe and generate enough pressure to open the airway, that's a lot of work. So what pressure support does is it just opens up the conducting airways so it becomes easier for the patient to breathe. Doesn't wear them out, doesn't wear out their diaphragm, doesn't cause extraordinary metabolic overdrive or overload, really can be beneficial for the patient. So very important for us to assure that we are really looking at pressure support in the way in which it was meant to assist our patient, which is to reduce the amount of work they have to use to get gas in and out of the lung. But if I'm going to move from SIMV with pressure support on the intermittent breaths, right? The mandatory breaths might be set at 10. Patients breathing 16 times a minute. That's 6 breaths above 10. Those 6 breaths have pressure support. If I now say, okay, now I'm going to put the patient on pressure support ventilation, I need to be prepared for extubation. And I'm not going to leave my patient on pressure support ventilation for a day or 2 or 3, because all I'm going to do is ensure that they're going to get exhausted and they're not going to be able to effectively be extubated. So I've got to really think about those modes. Pressure support ventilation, standalone pressure support ventilation is a test for extubation, should be employed for 30 minutes or less. And if you can't get 30 minutes, you can never do it for longer than an hour. You're just going to wear your patients out and they're going to fail extubation. Okay. We put patients on pressure support ventilation because that helps them to decrease their workload. They'll move more tidal volume. They won't have to work so hard to breathe. They won't have to breathe so rapidly. We're just opening up their airways. And remember, it's partly compensating for the ET tube. So remember, if your patient has a 30-minute success on PSV, you extubate, but you're worried about them, extubate to BiPAP, non-invasive ventilation. Promote that, ask for that, talk about it, right? 30 minutes, my patient's done pretty well on PSV. We want to extubate, and the doc says, oh, I'm kind of worried we might have a failure. You know what? You might have a failure. But if we extubate and we go to BiPAP, we can give the patient some support in a non-invasive method, 12 to 24 hours, and then see if the patient can come off BiPAP. Maybe goes to CPAP, maybe he just goes to a nasal cannula. Don't know that yet. Got to test the patient, got to trial the patient. But we have a responsibility to do the right thing. So when the ventilator gets set up, this is just post-intubation, we're going to think about a couple of things. FiO2, tidal volume, respiratory rate. Remember, tidal volume, respiratory rate, or minute ventilation. We're going to think about making sure initially that the patient has time for exhalations. So that would be 1 to 1.5 or more, 1 to 2, 1 to 3, 1 to 4, 1 to 1.5 is the lowest limit that you can accept. So as you increase the respiratory rate, keep an eye on that I to E ratio. We're going to adjust PEEP to actually open the alveoli and keep them open. We're going to think about the alarms that are set on our ventilator. We're going to think about sedation and paralysis. So I just want to remind you, FiO2 is not without harm. FiO2 is incredibly and profoundly harmful to our patients. It overwhelms the neutralizing system for oxygen. That causes an increase in what we call reactive oxygen species, that's ROS. Reactive oxygen species destroy the vascular surface and the endothelial surface. So not only do we want to be sure that we don't allow our patient to drop their oxygen, we cannot allow their oxygenation to be too high. Anything greater than 150 in an ICU in an intubated patient, you need to be on the phone right away. You cannot allow patients to be hyperoxic. Now, when we intubate the patient, we start with an FiO2 of 100%. We're going to titrate that down as soon as possible, and we're going to do it quickly. The only patients, there's a few drugs that actually put patients at very high risk for oxygen-generated lung injury. Amiodarone is one of them, bleomycin is one of them, and there's some others. But amiodarone is really the most common one. Patients who are receiving amiodarone are very at risk for oxygen-destructive processes. So we have to actually think about that patient and start with a lower FiO2. You as a provider should anticipate, facilitate, discuss decreasing FiO2 as soon as possible. So you can use your SAT. You're waiting for a blood gas. Maybe no one wanted a blood gas. They said, we're looking at the SAT. We need to titrate that FiO2 down. Now, we'd like to see your PaO2 between 80 and 150. Anything lower, anything higher, we're going to be concerned about, okay? If it's higher, just turn down the FiO2. If it's lower, you should anticipate an increase in PEEP to open up the lung so that we have better gas exchange. Now, if I'm at the bedside and I'm titrating down and my patient's SAT falls, I'm going to advocate to increase the PEEP. I don't want to go back up on FiO2. I can do it for a short term, but I want to remind myself that this can cause significant, profound lung injury. It can cause coronary vasoconstriction, cerebral vasospasm after a subarachnoid hemorrhage or a TBI. I have to be really clear that high FiO2 is dangerous. It creates many problems. So I don't want that to happen for my patient. Okay, well, I've got an FiO2 of 100%, but I can't oxygenate the patient. The SATs are 85%, they're dropping. Well, first of all, you got to get a chest x-ray and you got to bring the mean airway pressure up. So first, you're going to take the patient off the ventilator. Don't allow them to sit on the ventilator if they're desatting. Put them on a bag tube. I always say bag mask, but bag tube. And you need a PEEP valve, and that PEEP valve needs to be at 10 centimeters or greater. So first of all, you're going to diagnose the patient, because as you are bagging them, if you feel increasing resistance each time you bag, you've got a pneumo or a hemo. If you're not seeing increased resistance each time you bag, you're just going to try to recruit the alveoli. And you don't want to do this too fast, but you need to have a PEEP valve on your bag. So when you know you're getting a vented patient into a room or your patient has got ventilated, assure with respiratory therapy that you've got a PEEP valve and that the PEEP valve is set at around 10. If your patient arrests, you take them off the ventilator. If you have concern that you're not actually saturating your patient, you cannot be ventilating them without a PEEP valve. Okay. Now on the ventilator, we're going to increase PEEP. That's our first choice. We're going to increase PEEP to increase the mean airway pressure, which means that we're going to try to get that lung open. Now there's other things we can do. Pressure control, APRV, also known as bilevel ventilation. We can give the patient nitric oxide. We can do prone ventilation. We can put them on VV ECMO. But most importantly, in a basic ventilator course, the most important thing is when your patient can't respond to oxygen, it means the probability is there's a problem with the conduction of gas, either in the conducting airways or in the alveoli. So you as a bedside nurse, you as providers, you need to follow the P to F ratio. When that is falling, you can put your FiO2 up, but only for a short time, never really more than 30 minutes. Get somebody there. Get a chest x-ray, bag the patient, make a diagnosis. And by the way, as a bedside provider, you have to take the patient off the ventilator and bag them. They're desatting. Is there an obstruction? Is there a vent failure? Take them off the ventilator. Do not allow them to desat while people are fiddling around with the ventilator. Off the ventilator, bag the patient with the PEEP valve at 10 centimeters or more. Turn up your FiO2, bag your patient. Don't allow panic to overtake you. Don't bag too fast, just at the rate that the patient was breathing at before, and watch their SAT either improve or get worse. If the SAT gets worse, you've got pneumothoraces, you've got a hemothorax, you've got another problem. Okay, so really important to appreciate that we have this, what we call the sweet spot, which means this is the area that the lung is open. Now, I'm not asking you all to actually evaluate that. It's just, this is a really important tool in understanding how we want to set our PEEP. So I'm going to give you 2 more slides and then we're going to end. 2 alarms that are going to go off at the bedside. Peak pressure alarm. Whenever that alarm sounds, the breath is terminated because too much force is being generated when delivering the volume into the lung. Could be that the patient is fighting the ventilator, he has a pneumo, he has the hemo, he has a loss of alveolar compliance, he might have a mucus plug, the tube could be in the wrong position, it could be kinked, lots of problems here, okay? So whenever I see a peak pressure alarm going off, I don't just reset it and walk away. I have to evaluate the patient. And what I'm going to do is I'm going to ask my therapist, or I myself, if my therapist has approved it and has shown me how to do it, we're going to press an inspiratory hold button. So what that does is we flow gas into the lung and we close the exhalation valves. That gives us what's known as the plateau pressure. The plateau pressure actually tells me about compliance of the lung. Okay. This is a plateau pressure that I measured on a patient, took a picture of it so you could look at it. You can see up here, it says P-plat 16. See that white line? That's the plateau pressure. That is designating my patient's alveolar compliance. So we're always going to base our PEEP based on the P plateau pressure. Patients who are requiring high amounts of FiO2, we're going to utilize PEEP. We can go up to as high as 25 before we have to think about an alternative form of ventilatory support. From my point of view, every person at the bedside, at the most minimal level, needs to know the mode: assist control, SIMV, pressure support, the target, volume or pressure, and what that target is set at, 400 for volume, 40 for pressure, whatever that is. You need to know that. The patient's PaCO2 and minute ventilation, because the minute ventilation is what affects the PaCO2, and the patient's P to F ratio and their PEEP. And remember, if you're on high FiO2, you should be discussing going up on the PEEP so you can reduce the FiO2. We're going to base our PEEP on lung opening. That's called the P plateau pressure. P plateau pressure tells me when I have a much bigger lung, because the plateau pressure will be high when the lung is small, and it will be much lower when the lung is big. Okay, I'm going to say that again. Plateau pressure will be high when the lung is small, and it will be much lower when the lung is big, because I'm putting a size 12 body into a size 2 dress, that's the small lung, or a size 12 body into a size 14 dress. That's the compliant lung. When plateau pressure is high, it means that your lung cannot accept the volume that's being delivered. So we have 2 main choices. We're going to protect the lung by pressure control, or we're going to protect the lung by a lower tidal volume. That's protecting the functional lung, but it is not opening the rest of the lung. We're going to open the rest of the lung, or we're going to try with PEEP. I'm going to end here. It's 4 minutes before 5. I thank you for your attention. I'm going to have a second round of this because there are other things that we want to discuss, particularly talking about sedation, vent weaning trials, sedation holiday, how we should be weaning patients, when we should be considering it. And so that will be in part 2. I thank you very much. And I'm going to say goodbye for now, which of course means that I'm going to stop recording, but I will be available for questions. Thank you so much.